All right, good morning, everyone. Thank you for joining us today. I'm Connor McCallum with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Assessing and Treating Non-Suicidal Self-Injury. So before we get started with the presentation, I'm just going to take a moment to orient everyone to the Zoom system so you know how to participate today. So everyone has been automatically placed on mute upon joining the webinar to avoid distracting background noises, but we do encourage everyone to participate in the event using the chat box feature. So if you don't see the chat box right now, just click on that little speech bubble icon that's at the bottom of your Zoom screen, and the chat box should pop up for you. And please chat in your questions and comments at any point during the presentation today by chatting to everyone. We will be keeping track of all the questions that come through the chat box, and we will address them during the Q&A portions of today's event. So please feel free to chat in your questions whenever you think of them. We'll have a break in the middle for some Q&A, and then we'll also have time for Q&A at the end of the presentation. And if you have any technical issues at any point during the event, please chat to hosts and panelists, and our host, Kiara, will be able to assist you. And we do have a brief feedback survey that will pop up in your web browser when Zoom closes at the end of the webinar. So we would love if you could just take a moment to share your feedback with us on today's event, and also let us know if there are any topics that you're interested in seeing us cover in the future. And today's webinar is being recorded, so the recording and slides will be posted on our website, ctechny.org, within the next couple of days. And we'll also be able to post some of the links to some of the resources that Dr. Westers will be discussing today. So you'll be able to refer back to those resources on the website. And we are very excited to have with us today Dr. Nicholas Westers. Dr. Westers is a clinical psychologist at Children's Health and an associate professor of psychiatry at UT Southwestern Medical Center. He is board certified in clinical child and adolescent psychology and serves as the current director of programs for the Society for Adolescent Health and Medicine annual meeting. And he serves as chair of the Media and Communications Committee of the International Society for the Study of Self-Injury. His clinical and research interests focus on adolescent non-suicidal self-injury, depression, and high-risk behavior. And he is the host and producer of the Psychology of Self-Injury podcast, which is a resource for parents, professionals, and people with lived experience of self-injury. So we're very grateful and excited to have Dr. Westers here with us today. And thank you to all of you for tuning in. And I'll now pass it over to Dr. Westers.
Wonderful. Thank you. I am in Dallas, Texas right now, and I know everyone's an hour ahead in New York for the most part, but I'm talking about a topic I'm really passionate about and how I became interested in this. I was a sophomore in college, a psychology major, and a couple of friends disclosed to me that they had been cutting specifically. And as a psychology major, as a friend, I wanted to help them. So I started researching what we knew about self-injury at the time, and we didn't really even call it that at the time. That was back in the day when you would call it self-mutilation or just cutting, and there was just nothing out there. And so I ended up, when I went to graduate school, focusing my dissertation and research on non-suicidal self-injury, and just at the time that it became known as non-suicidal self-injury, or NSSI for short. So here in Dallas, I do a lot of clinical work with adolescents who self-injure, as well as do writing and research on non-suicidal self-injury. We'll talk a lot about, I'll use a lot of examples of adolescents and young adults, but this applies also for adults who self-injure, for those of you that treat adults who have a history of self-injury. My training was as a generalist, so I've worked with all ages, but now I primarily work with adolescents. So this is the podcast Connor was just talking about. I launched it last year on January 1st of 2021, and we'll be releasing an episode. Right now it's about once a month, and it really is a resource for parents, professionals, and people with lived experience of self-injury. And we have our next episode lined up either next week or the week after to be released on self-injury across cultures, where I interview a researcher out of New Zealand, and I interview a lot of people throughout the world that are leading experts in the area of non-suicidal self-injury. So you can check out the podcast. It's available on all major podcast platforms, as well as simplecast.com, which I put the link there at the bottom. And today, the first half of the presentation is really going to focus on what we cover a lot in episode 2 of the podcast. And then the second half of today's presentation is going to address what we cover in episode 10, T-SIB, Treatment for Self-Injurious Behaviors. And those 2 episodes are 2 of the top 4 most popular episodes of the podcast. So hopefully you'll feel this way after the presentation as well, that you'll hopefully learn a lot. Ideally, by the end of today, my hope is that you'll be able to explain key characteristics of non-suicidal self-injury that may increase risk for future suicide attempt, as well as recall at least 3 important questions to ask individuals, really, not only youth, but individuals who self-injure. And there's many questions you can ask, and I think there are really 3 or 4 really important ones. And then the second half of the presentation, really talking about treatment strategies, and hopefully you can explain some of the treatment strategies I'm going to talk about 2 specifically today. So here's an overview. For the first hour, we'll touch on defining NSSI, and then we'll talk about the prevalence rates, DSM-5 updates, and then spend the bulk of this first hour talking about assessing and responding to individuals who self-injure using the SOARS model, which is a model I published about 6 years ago in Contemporary Pediatrics, which is one of the resources that Connor had mentioned is available. And then we'll do some Q&A, and then the second hour we'll hone in on 2 of those treatments, the treatment for self-injurious behaviors, as well as emotion regulation, group therapy for really adults, but ERGT is what it's called. There's a version for adolescents, and I'll share some resources, and we'll have some time for Q&A there at the end. I like to make sure that we're all on the same page when we talk about non-suicidal self-injury. It's under the broad umbrella category of what we call self-harm. So when I'm talking about self-harm, I'm talking about suicide behavior, NSSI behavior, substance abuse, misuse, eating disorder behavior, intentionally risky sexual behaviors to cause harm. So self-harm is an umbrella category under which is each of these, as well as non-suicidal self-injury. So when I talk about non-suicidal self-injury, although an imperfect definition, I mean it's purposely inflicting injury upon oneself that results in immediate tissue damage, is done without suicidal intent, and not socially sanctioned within one's culture, nor for display. So self-tattooing, or just tattooing in general, does not quite fall into that category because it's culturally sanctioned, at least here in the US and in other cultures as well. So even if it's done to intentionally cause pain and harm while getting that tattoo, we just don't call it NSSI. And this is borrowing from the International Society for the Study of Self-Injury definition of NSSI. I like to differentiate it, like I already did, from self-harm. Self-harm is the umbrella category under which NSSI is just one method of self-harm. And I also differentiate it from atypical severe self-injury, what we used to call self-mutilation. Self-mutilation is just an outdated term, and no one uses it anymore, at least anyone that knows anything about self-injury. It was really a misnomer, because back in the 80s, 90s, and early 2000s, when people would use that term, it really didn't describe the behavior as much as it described the affective reaction to those addressing and treating the behavior. So it was really more of a reflection of treatment providers saying, oh, how could anyone do that? And people aren't typically mutilating themselves. Now, there are atypical severe forms of self-injury, ones that do require significant medical attention. If an individual maybe cuts off a finger, or engages in self-castration or eye enucleation, removing their own eyeball. And those are usually done in episodes of psychosis, whether schizophrenia spectrum disorder, or any type of other psychosis, or substance-induced psychosis. So those are very rare. So we're not talking about that today, just to be clear. And then we're also not talking about stereotypic self-injury, which is what you would see in individuals with autism spectrum disorders and intellectual disabilities, where there's that repetitive head banging or repetitive stereotypic behavior. On the other hand, individuals on the spectrum, as well as those with intellectual disabilities, can engage in non-suicidal self-injury and or stereotypic self-injury. So they do still, this talk also still applies to them. Epidemiology prevalence studies. The first study was done in 1988 and found that less than 1% of the general population had engaged in self-injury at some point. A decade later, we saw the number was 4% instead of 1%, or just under 1%, and then 21% of clinical populations. And then another decade later, in 2007, we found that about 10 to 28% of adolescents in the community reported having self-injured in the last year. And then that was about 40 to 80% of adolescent psychiatric inpatients. So we started finally looking at younger people where the behavior was more prevalent. And then in 2012, this is a study that you'll see cited still quite often, that globally, about 18% of adolescents specifically engaged in self-injury at some point in their life. And that's about 6 to 9% for adults. It's really hovering around 6%, 5.96%, depending on what meta-analysis that you look at. So adults also self-injure. And I probably should have added that there to the slide. And then 6 years later, so we're talking about 4 years ago, a meta-analysis was conducted again and published, and found that across the world, globally, 22.9% of adolescents, this was only looking at adolescents, 22.9% reported having self-injured at least one point in their life. And that was 18.6% reported having self-injured at least once in the last year globally. And then in the US specifically, that number was about 17.6% of high school students reported having self-injured in the last year. And then US high school students, 12-month prevalence rates of those who self-injured 4 or more times was 7.7%. And then those who self-injured 6 or more times was 5.5%. So it's obviously something that all of you are seeing in your clinical work and probably in the community in general, and have friends or family that have self-injured. And overall, I think it's safe to say about 1 in 5 adolescents have self-injured even in the past year globally, and then about, again, 6% of adults have self-injured. Oh, that was going to highlight that. As most of you know, or all of you probably know at this point, in the latest edition of the DSM, the Diagnostic and Statistical Manual of Mental Disorders, there was a proposed condition that they called NSSI disorder. There's also one for suicide behavior disorder, but this is not an actual diagnosis, and there's a good chance it will be at some point in an additional edition of the DSM, I suspect, but the criteria are going to be very different. Well, I don't know about very different, but they will be different. For instance, criterion A says that in order to meet criteria for NSSI disorder, someone has had to have self-injured at least 5 or more times in the last year. But then it doesn't really clarify, is that 5 or more days in the last year. That doesn't mean necessarily that, what if they self-injured multiple times in one day, multiple episodes throughout a day, but only 4 days, like that doesn't quite capture that, or number of injuries per episode. So that doesn't really capture that. So it's imperfect, but research right now is showing that 5 or more days may not actually meaningfully differentiate between clinical and subclinical or non-clinical groups of those who self-injure. So the current criteria actually might be too liberal and over-pathologize those who engage in self-injury just intermittently. And in fact, the majority who actually meet criteria, this criterion A, they actually report an average of well above 10 or more episodes or 10 or more days of self-injury. And then 4 or more days in the past month actually might be more clinically useful when we're talking about diagnostic criteria. So that will actually differentiate those who would meet the disorder of NSSI versus just the behavior at intermittent NSSI, kind of like depression. We don't, just because someone feels depressed doesn't mean they have a major depressive disorder because they don't meet all the criteria, but that doesn't mean that their feelings of depression are any less important to address. So even if it's non-clinical and subclinical, it's still important to address. Criterion B looks at expectations and says at least of these 3, 1 or more of the following expectations must happen. But the problem is almost everyone reports 1 or more functions of self-injury, regardless of how frequently they engage in the behavior. And in one study, 98% who endorsed this criterion or met this criterion B, also met criterion C. So it didn't really differentiate well between clinical and subclinical populations or non-clinical populations. And then criterion B2, in fact, did not differentiate threshold versus subthreshold across either community samples or clinical treatment samples. So again, in this case, criterion B, the current criteria don't meaningfully differentiate between clinical and non-clinical or subclinical groups. And then if we look at criterion C, so we looked at expectations in criterion B, C looks at more the precipitants, the triggers, and almost all endorse criterion C1. It's like there's almost always some sort of precipitant that's either interpersonal or unpleasant feelings and emotions. So almost all. And then criterion C3, frequently thinking about NSSI, is actually the only symptom in studies that show that it was associated with suicidal ideation. So criterion C, there's some clinical utility in arriving at an NSSI diagnosis. The most important criterion though here of all these is E, criterion E, that it causes clinically significant distress or interferes with functioning, because significant differences in studies exist between those who meet all criteria, all 1, 2, 3, 4, 5, 6 criteria for NSSI disorder, versus those who meet all criteria except for criterion E. So 5 of the 6 criteria. Compared to those meeting full criteria, those who did not endorse criterion E reported onset of self-injury at a later age, fewer social functions of self-injury, fewer suicide attempts, and significantly lower levels of symptoms of anxiety and post-traumatic stress. So there's some clinical utility in arriving at an NSSI diagnosis in criterion E. I wanted to put this up there. There's considerations of expanding even these diagnostic criteria, because they look at more specifically the expectations, so the cognitions, and then the behaviors. But only those who have actually crossed that threshold and engaged in the behavior would fall under meeting the criteria of NSSI disorder. And so here they suggest that there's also those cognitive processes, those self-injury to, or thinking about avoiding emotion or a situation and being able to modulate the response. And then part B talks about the act of self-injury can be contemplated for some time before expressing it behaviorally in part B. And then by expanding the diagnosis, I'm reading the caption here, to capture individuals both in areas A and B, the factors that ultimately cause the individual to self-injure and acquire learning regarding this behavior may be uncovered. So in identifying patients prior to non-suicidal self-injury is equally, if not more important than diagnosing those who have self-injury. So I think the nice thing here is it captures, again, those who may not engage in the behavior, but experience emotionally distressing urges frequently that interferes with their day-to-day functioning. And then the question, though, becomes, if this were to become a clear diagnosis, an NSSI disorder in the DSM, under what category would it fall? Would it fall under depression? No, not necessarily, because people can self-injure without experiencing depression. Well, what about anxiety disorder? Same thing. People can self-injure without experiencing anxiety disorders. So right now it's suggested that it would fall under the disruptive impulse control and conduct disorders, as that being the most appropriate diagnostic category according to research and surveys of clinicians like yourself. Now let's talk more about the more important and interesting stuff. So this is the SOARS model, which I published in the July 2016 edition of Contemporary Pediatrics. It's open access. This is a PDF version. There's a web-based version that you can find online. You just probably look up SOARS model, self-injury. And I developed it because I was training our pediatric residents that rotate through our adolescent and young adult clinic every month here at Children's Medical Center in Dallas at Children's Health. And they just never were exposed to training. They were never trained in addressing self-injury. And if they did, it was just a kind of a side comment when they were trained in the very limited training that they received in suicide prevention and suicide screening. So this was really to meet a need. And I wanted to come up with a way that, well, really 3 things. One, what questions are the most, if they only had 5 minutes, what questions should they ask? Because I know they're busy clinicians, you're busy clinicians, your intake, you don't want to spend all intake asking about this unless this is really the primary presenting concern. But what questions to ask? 2, why should we ask those specific questions? So based on theory and research. And 3, how should we ask those questions? So because wording matters. If anything we know in psychology is nuances of words matter, and how we phrase things really matter. And it's an art sometimes. And then I wanted to be able to help them to remember what questions to ask. So I created this acronym SOARS. So even though I wrote it with pediatricians in mind and residents in mind, this is also very applicable to all of us as mental health professionals. So that I had us in mind as well when writing this. But more importantly than any of those questions, and a lot of you from your own experience know that how we respond, our interpersonal demeanor, is much more important than even what we ask, because it's none of us intentionally comes across as judgmental. At least I would hope not. If so, we might need to find another profession, right? If we're in here just to judge patients or clients. But we do sometimes on our bad days, or times we just make a comment that is a little less sensitive, or maybe that our client or patient is more sensitive than in a typical day, and they just interpret something negatively. And so we sometimes accidentally make comments or say things in a way that come across as judgmental. And so I'm constantly thinking about this when I'm working in therapy with my patients and clients about self-injury. And it's so important to use a low-key, dispassionate demeanor and a respectful curiosity. Again, we're just using just matter-of-fact language, not judgmental. We're not saying, why would you do that to yourself? Well, like, there are different ways. There's another way to ask that that's less judgmental. And even if we did want to just straight up tell them to stop self-injuring, which might work for some people, just being told to, we're going to advise against self-injuring, of course, for health and mental health reasons, but just telling someone that they have to stop might just make them not tell us. They keep self-injuring, but just won't tell us. So that's why it's important to have a good, low-key, dispassionate demeanor, respectful curiosity when we're talking with individuals who self-injure, and then using a validating stance. And we'll talk about that in a little bit. And there are a couple of papers that I wrote that I'll probably share with resources. One that's not, it's in press right now, and that should come out later this year, hopefully sometime this summer, the Oxford University Handbook of Non-Suicidal Self-Injury, where I talk about first responders, which are often medical providers, but also times mental health providers, the first to learn about self-injury and the way to respond. And so here in the paper is the actual acronym, SOARS. And if there's a version 2.0 of this, what you'll likely see me do is switch the two S's from suicide ideation to the first question to be the last question, and then start with S, stage of change. Because talking to individuals with lived experience, I learned a lot. And co-authoring that paper that I just mentioned for first responders, that's going to be a book chapter in the Oxford University Press Handbook of Non-Suicidal Self-Injury, had suggested that if you were to be asked like straight up about suicidal thoughts at the beginning, that she might be turned off because she knows kind of where that would be going. But we always ask about suicidal thoughts anyway during our intake, at least here where we are, and I recommend universal screening. And I know just, I think in Division 53 listserv of APA, there was some disagreement with that, but I think that's more stigmatizing than not. I think but that's a different topic. So usually I recommend asking and screening for NSSI worded in this manner. Have you ever hurt yourself on purpose without intending to end your life or attempt suicide? Now, I used to stop there, but I've since added the second part of the question with examples like cutting or burning or biting, hitting yourself, severely scratching yourself. And the reason why I suggest adding examples like that is because we know prevalence rates change depending on how the question is asked. And when it's just asked, have you ever hurt yourself on purpose without intending to end your life or attempt suicide, prevalence rates are lower. Really for two reasons. One, because when people think of self-injury or NSSI, there's one method that comes to mind. Like, what method is that? I mean, you can just think about it. Cutting, right? Cutting is the one method. But what if you don't cut? What if you burn yourself or severely scratch yourself, or engage in using like an eraser to cause an abrasion on your skin, or self-hit? That misses those individuals, as well as those who don't necessarily identify as an individual who self-injures. They might not think of that. So research shows that how we ask the question matters. And giving examples actually results in higher prevalence rates. And there's some alternative assessment models that there's higher stops fire. Stops fire is just too long. So one of the authors is a co-author on the SOARS model. So I didn't want to compete necessarily with her, but I wanted to make it an abbreviated model that would be easier to use for screening. So let's walk through each of these. And if you had time for, like, you could spend an entire clinical interview doing this. Again, this first hour, we're just talking about assessing and responding to NSSI. The second hour, we're talking about treatment. But when I'm working with pediatricians, I recommend at least like if they only have time for 5 minutes, to go through SOARS. But if they don't even have time for 5 minutes, the 3 key questions I recommend to them are the S, the A, and the R: suicidality, aftercare, and reasons. Unless you're a medical professional attending today, the A might not be as important as the O. And the O is going to be multifaceted. It's really onset, frequency, and methods. But let's start with suicidal ideation. You can ask this at the beginning. I usually will ask I'll screen for suicide ideation, and then I'll move to NSSI. And I usually will do that after I talk about more, like a lot of easier topics to kind of get the conversation going. But I'm not sure where each of you are, but you can use this however you want. You can ask it later, ask about suicide at the end or at the beginning. It just depends on your comfort level and probably your clinical setting. Most of the kids that I see come to me because of suicidal ideation and or NSSI, or they've attempted suicide. So it just makes sense for me to ask. They know what they're here for that reason. But why do we ask about suicidal ideation? Well, really for 2 reasons. One is research has shown, including here's at Children's and UT Southwestern in Dallas before I even started working here, that at least among adolescents, and I think and also I believe with adults, some studies have shown with adults, that adolescents with depression who self-injure are actually at greater risk for attempting suicide than those very adolescents that have already attempted suicide. So NSSI is a stronger predictor of a suicide attempt than a past suicide attempt is. Now, of course, the best predictor of future behavior is past behavior. So if you've attempted suicide in the past, then you're at significantly high risk of reattempting. So that's still a concern. But those who haven't even attempted suicide, but engage in NSSI and have depression are even at greater risk for attempting suicide later. So NSSI is a robust risk factor for suicide, even though it should not be confused with a suicide attempt or suicidal behavior. And the second reason we want to ask about suicidal ideation is for some individuals, if we think about self-injury as a coping strategy, and hopefully you do, because it really is a way to cope and regulate emotions in general. Some individuals self-injure because they have suicidal thoughts, and the only thing that they find that helps them refrain from acting on those suicidal thoughts is to engage in non-suicidal self-injury. So what we know though from research is that of all the functions of self-injury, if an individual self-injures to avoid suicide, so that's the function of the behavior, that's actually the function most closely associated with attempting suicide. So we want to ask the functions, which we'll get into in a little bit, but that's one reason why we ask about suicidal ideation. And I recommend starting by making a statement. Again, it's all about language and a low-key dispassionate demeanor and respectful curiosity. And start by saying, I know self-injury isn't usually about suicide. So here you are demonstrating to your client that you understand that their behavior, you're not going to misconstrue it as a suicide attempt. But you want to make sure but some individuals who self-injure do think about suicide. And so you make that comment, but some people may think about suicide when they self-injure or whatever method that they endorse. If they said they cut or if they burn, that you can comment that some people may think about suicide when they burn, when they cut. And it's important to do this, I believe, because I have worked with a number of young people who have gone to the school nurse or someone at school for a source of support, non-suicidal, no suicidal thoughts at all. And they go for support, and then they call the nurse or the school counselor calls 911. And this has happened like 2 or 3 times in the past, not recently, fortunately, but they were escorted out by the police in handcuffs and taken to the emergency room unnecessarily. So from a public health perspective, that's just problematic because it's costly financially and unnecessary, and 2, because it clogs the emergency room when they're already really busy with behavioral health, mental health concerns, and these individuals don't necessarily need to go, especially if they're low risk and that's non-suicidal. So I like to acknowledge this, like, hey, listen, I know that this isn't necessarily about suicide, but for some people, they might think about suicide when they self-injure, and then directly ask them, do you ever think about purposely ending your life whenever you cut yourself, whenever you burn yourself? And it's okay to ask. There are no iatrogenic effects, just like there are no iatrogenic effects when asking about suicide. It's not going to put the idea in their head if they haven't already thought about it. It's not going to put the idea in their head with self-injury if they've not already thought about it. or heard about it, because for the most part, everyone has heard about self-injury nowadays. You might not have heard the term NSSI or non-suicidal self-injury, but everyone knows at this point about cutting for the most part. So it's not like some scary or unknown thing nowadays. So that's why we want to ask about that. And that would be really important. That's like one of the three most important questions. Next is the O. So this is probably the most important for us. The O actually is 3-in-1: onset, frequency, and methods. Onset really assesses duration. Frequency assesses lifetime number of episodes, and methods assesses number of different types of self-injury. So cutting is just one method, whether it's with a piece of glass or a box cutter, or what I see most popular now is those little plastic pencil sharpeners that have one screw. They're easy to unscrew and then take the little small sharpener blade for the pencil, and just easy to hide, and they're sharp. Others have just like stomped on, that because they're just plastic and easy to access, and they're easy to hide. So they just stomp on the plastic pencil sharpener and access it that way. That's used to be box cutters being the most popular. Now I think those are the most popular. Scissors are often popular, although scissors tend to result in more of a scratch than a cut, but if they're sharp enough. But yeah, it doesn't matter. Just cutting is one method. Another method is similar to cutting. We call it carving, which is cutting words or symbols into the skin. And I work with a number of individuals, and I have in the past as well, with eating disorders. And I find this pretty often common among individuals with eating disorders. They may carve the words fat into their skin, or ugly, or hate, or they might like cut an X over their stomach. And I've worked with young people who've done that. And it is cutting, but it's just qualitatively different. We consider it a different method. So it's cutting, carving, and then I mentioned like using an eraser to cause an abrasion. There's burning. Research has shown that the greater number, most people self-injure like using more than one method, usually 2 or 3 methods. But research has consistently shown, including ours here that we've done here at Children's and UT Southwestern, that the greater number of methods, different methods of self-injury, the greater likelihood of attempting suicide. And that's consistent across all studies. So when I'm asking about methods, I just want to ask, like, what have you used? Like looking at the bottom question there, what do you typically use to self-injure? And then I'll ask about the different methods of self-injury. What do you usually use when you cut? What do you usually use when you burn? To get like a good understanding of that. Onset really assesses duration. Research is more mixed here. Some research shows that the greater number of years of self-injury, the greater likelihood of attempting suicide. Other research doesn't show that, but I think that's because it's how it's measured. If research is asking a 17-year-old how many times they self-injured, and they did it once when they were 13, once when they were 14, and then once when they were 17, that's just 3 episodes, but it's like 4 or 5 years in research versus a separate 17-year-old, for instance, that might come this afternoon to see you for therapy, who's been self-injuring every day for the last 6 months. In research, that's only going to be like 0 to 1 years of self-injury, but clearly a more clinically and acute concern for you. So research is mixed with that, but research has shown that early age of onset is associated with later attempting suicide. Early age of onset being 12 and under. So if someone starts self-injuring when they're 10, that's a concern, of course, but if they continue past their, into 12, 13, 14 years old, they're at elevated risk for attempting suicide. So so I'll ask, when was the first time you self-injured for each method? When was the first time you cut? When was the first time you hit yourself or burned yourself? And then when was the most recent time? So for frequency is more lifetime number of episodes, and research, including ours here at Children's and UT Southwestern, show that the greater number of episodes of self-injury, the greater likelihood of attempting suicide, and the greater likelihood of attempting suicide multiple times. So the greater number of self-injury episodes. Some research has shown more of a curvilinear relationship, such that risk for attempting suicide increases as number of episodes of self-injury increases, and peaks right around 21 to 50 episodes, and then declines. It remains high afterward. And if you conceptualize self-injury as a way to cope with overwhelming emotions, it makes sense that we might see this curvilinear relationship. Because if someone has self-injured 200 times, 300 times, then clearly it's working for them as a go-to coping strategy. But someone that might be really overwhelmed, who's just now self-injuring 21, 22, 23, 24 times, they might be more at risk for attempting suicide should they have any co-occurring suicidal thoughts. So that's why we want to look at frequency. And I typically say, I don't ask adolescents or really even adults this, like how often they do anything. I usually just say how many times a week. So let's put this to practical use. Let's say you see a new client this afternoon in your clinic or at your practice, and you ask them like when the first time they self-injured, they said 6 months ago. When was the most recent time? This past weekend. So you have your duration of 6 months, and then how many times a week do you self-injure? And they say, no, I don't self-injure every week. I don't cut every week. So you might ask, how many times a month? Well, I cut maybe 2 or 3 times a month. So then you can quickly do the math. So twice a month for 6 months, you have 12 episodes. 3 times a month for 6 months, you have 18 episodes. So they're between 12 to 18 episodes. And you're thinking, okay, they're getting close to that 21 to 50 peak that I want to keep an eye out for risk to make sure that if they have any co-occurring suicidal thoughts, that I want to be really monitor and do good safety planning at that point. And then I added this question here. You can see, have you found that you've begun to self-injure or cut whatever method more often or more deeply than a year ago or whenever you first started? There is one study that looked at pain that found that those who don't experience much pain at all when they self-injure are actually twice as likely to attempt suicide. And this brings up the question and the reason why we ask these questions in this one, the interpersonal theory of suicide. Many of you are probably familiar with this, the interpersonal theory of suicide. It was developed and posited by Thomas Joyner, who's a suicidologist at Florida State University in Tallahassee. And based on his research, he published a book in 2005 called Why People Die by Suicide. And if we think about the greater, like the large number of individuals who ideate, who have suicidal thoughts, that's a large number. But then there's such a small number of those who attempt suicide. And if you follow the CDC data that comes out every 2 years on adolescents, like I do so intensely, the new data should come out this year with the Youth Risk Behavior Survey, the YRBS. Comes out every 2 years and assesses adolescents, U.S. high school students, representative samples throughout the U.S. on a variety of health risk behaviors. Some as innocuously, like seemingly innocuous as, do you wear a seatbelt, or how many times, how often do you wear a seatbelt, how often do you wear a bicycle helmet when you ride a bike, to how old were you the first time you had sex, how many times have you used cocaine, heroin, how many times have you carried a gun to school, and then asking about suicide. A few states ask about non-suicidal self-injury now, but if we look at the prevalence of suicidal ideation and attempt among U.S. high school students, the most recent data show that 18.8% of U.S. high school students reported seriously considering attempting suicide in the prior 12 months, which is a ridiculous number, 1 in 5, again, basically. 8.9% report actually having attempted suicide within the past 12 months, which is still like close to 1 in 10 high school students have attempted suicide in the past year is too high. I think we all agree on that. But what moves the 18.8% to become the 8.9%? And that's where this theory comes in, where 2 things have to be present and is relevant to our assessment, our risk assessment here. One is the desire to die, or what we would consider suicidal ideation. And the other is the capability to act on that desire. So what constructs make up this desire to die? Well, typically 2 constructs that really play out during the pandemic here. One is this perceived burdensomeness, and then the other is a thwarted belongingness. So thwarted belongingness, I just don't connect with anyone, I'm alone, which in quarantine, especially the first half of the pandemic, everyone was just, it's so alone, really. So I think there was an elevated risk there for ideation, for suicidal thoughts. But then there's also this perceived burdensomeness, like the world and my family would be better off without me. I'm just a burden on this world. And some, like, if we're honest, they are a financial sometimes burden, especially those if any of you work with individuals with the chronic medical conditions. There's some financial burden, emotional burden, long hospital stays, but burden doesn't always mean bad. I mean, I have a newborn. Well, he's not a newborn anymore. He's a 1-year-old. He's up many times at night. And we lose sleep because we're tending to him either because he's crying or in pain or sick. And that's a burden, but that doesn't mean it's a negative thing. I love him, and I show up. I signed up for this as his parent, as his father. So it's a burden, but it's not a bad thing. But a lot of times we talk about this burdenness being a bad thing. But either way, this perception that I'm a burden and that I just don't connect, thwarted belongingness, perceived burdensomeness increases my ideation, my thoughts of suicide. But that doesn't mean I'm going to act on it unless I've acquired the capability to act on those thoughts, which is developed by being exposed to what we call painful and provocative experiences, or PPEs. So the most painful and provocative experience would be a past suicide attempt. So of course, if you've attempted suicide in the past, you've acquired the capability to do it again. Another would be combat exposure for our active military members and veterans, or right now with the war in Ukraine. I mean, that's a lot of exposure to trauma and death, and that will increase the capability theoretically of some individuals for acting on any suicidal thoughts should they experience them. Past abuse, past or current abuse, physical, sexual abuse, substance abuse, misuse, even eating disorder behavior could be considered painful and provocative experience, as well as non-suicidal self-injury. So that what happens when we're exposed to painful and provocative experiences is two things. One, there's this habituation to pain over time, and two, a decreased fear of death over time, which ties us back into this slide where this longer duration of self-injury is this where someone might start self-injuring and not even think about suicide or be scared of the thought. They might start self-injuring more severely to get the same effect emotionally and relief emotionally than they did when they first started. So they start to habituate to the pain and they become less scared of death, and that places them at greater risk. And I think if we look at the different kinds of methods of self-injury and different types of pain, I believe that cutting, burning, and bruising are three different pains that would serve as each individually painful and provocative experiences. Cutting from like glass or scratching or the tearing type of pain. And then the bruising type of pain through self-hitting, self-biting. And then there's the burning type of pain, whether it's like using an eraser or using a lighter. So that's important for us to ask. And this is really more for medical providers, but and I won't spend as much time here, but I think it's important for us to also ask about aftercare. And we want to make sure we are assessing for the severity of the behavior and avoiding infection and scarring. Scarring is complicated for some individuals because it may represent the memory of what they went through. And a lot of individuals who self-injure have a complicated relationship with the scars that result from their self-injury. They sometimes like them, they sometimes don't, or they may have mixed feelings. But I recommend asking this, how do you typically take care of your wounds after? Ideally, they'll simply say, well, I just use soap and water. And then I might say, do you need a bandage or ointment? And then they tell me, it's like, oh no, it hardly bled at all. So for me, it tells me, okay, that's not that severe. But then I might ask, have you ever hurt yourself so badly that you could have used medical attention like stitches, even if you never got it? And this might get into the idea of habituation to pain, or someone who might accidentally self-injure too severely that might actually require medical attention. Or I've had kids who've become really angry after an argument with their parent and then cut on their forearm and then had to go to the emergency room, legitimately so, to get like sutures. And then I've had like others who've cut on their thigh a little bit too deep, and then they didn't tell their parents or they didn't tell anyone. And then as they continued to bleed over the days or as it started to heal, then they had some significant scarring that brings up more body image issues. Now, I'm not going to assume that a 15-year-old or a 16-year-old or even an adult necessarily knows every single time that they might need medical attention like stitches. But this question does let me know how severe the behavior is in their eyes. So, and I'm also not medically trained, so but most of the time we can tell if an injury is going to require medical attention. The other most important question to ask is reasons for self-injury. So this is actually very informative for the next hour of our presentation on treatment, because this is going to drive our treatment plan. But to get the information we need, similar to screening and asking about suicide ideation, I highly recommend starting with a statement first. Like, just try this, like with your next client who self-injures the first time you see them, or even if it's not the first time, simply say like, it sounds like, after you've asked these questions that we've already talked about, it sounds like this has been helpful for you. In what ways does it help you? I'm curious to know what it does for you. That's a respectful curiosity. Now, it's also validating. And some people say, oh, that means you're condoning the behavior. It's like, no, there's no saying like, oh, good job. Like, if I were you, I would do it too. There's none of that here. It's just simply an acknowledgement of what they're already doing and why they're using it and why they might be continuing. It's like, it really does sound like this is helping them in some way, at least emotionally. And I'm curious to know what it does for them. So again, this is where we want to refrain from saying, why would you do that to yourself? Like, the why questions are not really helpful. They just drive the behavior underground. So I'll ask like, yeah, in what ways does this help you? So the reason we want to ask this though too, is most people self-injure for multiple functions, usually to cope with emotions. But research shows that the greater number of different functions that the behavior serves, the greater likelihood of attempting suicide. And like I said before, if they self-injure to avoid suicide, that's actually the function of the behavior that's most closely linked to attempting suicide. Second to that is self-hatred, which is different than self-punishment. Self-punishment is like there's this perceived transgression. Self-hatred is this relationship with oneself that's so disdainful that they would harm themselves. That's the second most closely linked to attempting suicide. The third is to end feelings of numbness or dissociation, which just makes sense. If someone self-injures and they're just dissociated and then they are grounded back into that and then realize what they've done, that's clearly a significant concern. But common reasons, let me start with this. The most commonly believed reason that people self-injure, including among mental health professionals, is to get attention. But if you look at the research, that's actually one of the least commonly endorsed reasons for self-injuring. But so many times, even parents will tell me, oh, I think that they just do it for attention. Or teachers or school counselors or nurses or physicians or other psychologists and therapists are like, they're doing it for attention, it's gamey, it's manipulative. And I'll address that in just a moment. But very few, some people do for attention, but very few people do it for attention. But let's say that they do it for attention. We should give them the attention. Like clearly, if that's what they have to do to get attention, then maybe we need to pay more attention to them. But common reasons, the most commonly endorsed reasons are for emotional reasons, whether to find emotional relief that release that tension, or to end numbness associated, emotional numbness, and to feel something, even if it's pain. And then some endorse self-injuring to get attention, or what I like to rephrase it as to communicate with others or activate the resources in their community. And that's how they're doing it. And that's why there's the function of the behavior, which is much more empathic than saying, oh, just for attention. That's just so dismissive and unkind. And then some will self-injure to avoid a responsibility or an unwanted experience, where I see this in relationships a lot, where someone wants to break up. Like I see a teenager and their boyfriend or girlfriend wants to break up with them, or they want to break up with their boyfriend or girlfriend, and then their partners, when they try to break up with them, threatens to self-injure and or self-injures, and so they feel held hostage in the relationship. And then I put as an asterisk self-punishment, because I don't think it necessarily fits neatly within either of these categories. But let's talk briefly about gamey and manipulative as descriptors. Many of you I know, this is I'm not shaming anyone. We've all used the word manipulative to describe a behavior before, including non-suicidal self-injury, and that probably didn't cause a ton of damage. But I just want us to step back and think about that word for a moment. If I were to call you, or if someone were to call you manipulative, how would you feel? And the word manipulative is just inherently pejorative. And research shows that we can't infer the intent of anyone's behavior, really. It's just speculation. Unless the person just outrightly says, yes, I was trying to manipulate you, then probably, maybe they were manipulating you, but we can't infer the intent of anyone's behavior. And then perhaps most importantly is, few individuals or especially children and adolescents are so sophisticated that they can manipulate other people, unless they have like a weapon in hand. Then we're talking about, there's coercion and manipulation going on. But if we step back and tap into our training, our conceptualization, our case formulation, if we think about the example I use often is the kid with a caregiver at the grocery store in the checkout lane, who sees a candy bar and wants it and throws a tantrum, and the parent is embarrassed because they said no, you can't have it, the chocolate, that candy bar or whatever. And the child throws a tantrum, and that's embarrassing for the parent. So what does the parent do to get their kid to be quiet? They buy the candy bar. So each person learns something there. One, the parent learned, well, I just have to get them what they want and then they'll be quiet. But the child in that case learned, well, if I throw, even if it's unconscious, if I throw a big enough fit, a big enough tantrum, I will get that candy bar. So the next week, same thing happens. And then it happens again. Some might say that child is manipulating their parent. A good case formulation and good case conceptualization skills say that child was being reinforced for their behavior. In other words, basic principles of behavior psychology don't allow for manipulation in these cases. It's called operant conditioning, not manipulation. And so I just challenge you to refrain from labeling anyone's behavior as manipulative, especially at least as tied to non-suicidal self-injury, just because it's for the reasons I just mentioned. And lastly, and then we'll take a break with Q&A. This is a question you could ask at the beginning, but the stage of change. So the trans-theoretical model of change developed for smoking cessation, I've adapted it for addressing non-suicidal self-injury, recognizing that not everyone who self-injures wants to stop or sees it as a problem. And I'll ask them, is this something that you'd like to stop, or have you ever considered stopping? Which makes sense to ask it first during your interview to see what they want, to direct the rest of your interview with them. And I've worked with individuals who, I had a 17, 18-year-old who self-injured pretty severely, quite a bit. And I posed this to her, and she didn't want to stop. So I started asking, well, and actually, if we go back to reasons for self-injury, if you do a good job here and you validated what it does for them, this is where you can do a brief intervention too, or start your intervention and start asking them what it's costing them. So for her, I asked about her mom. I was like, well, your mom is really worried. And my patient said, yeah, but it doesn't hurt her in any way. It doesn't physically harm her. And my patient, she came from a large family, and she was closest with her 7-year-old sister. And one day her 7-year-old sister came up to her and had drawn all over her forearms with a red marker and said, look, I'm like you now. And for my patient, that's when it clicked. She went from pre-contemplation to contemplation and preparation and action very quickly, because she didn't want her little sister following in her footsteps. So she ended up getting these beautiful sleeves of tattoos, which covered her scars, but also served as a preventive function, because she didn't want to disrupt her new tattoo. She didn't want to mess it up. So it's really, so not everyone wants to stop. And I think if you do a good enough job exploring the reasons that the functions serve an individual who self-injures, then they'll be more likely to explore what might be costing them. And I was thinking we could, let's see, I have examples that I didn't share that I might share later for the sake of time. But let me just summarize here. So for all healthcare providers, if you're, for the mental health professionals or any medical professionals there that are watching, essential elements in all brief counseling, if this is all you had, if it's like a behavioral health intervention in a primary care setting, or your first session and you want to make it an impact quickly, validate that their self-injury seems helpful to them. I remember doing this with a 12-year-old who had cut herself with a razor from the shaver in her bathroom. And she had done it twice. And then I was on vacation at that point and came back, and she had told her mom, and she said, I asked her, it's not like, what did it do for you? And she's like, it didn't do anything for me. And then it was like a week later, she did it again for a third time, and she told her mom, so her mom was aware. And then she came in, and I said, it sounds like this has been helpful for you. I'm curious, because you did it 3 times, which suggests to me a pattern, and maybe there is something, something helpful for you in that. And in true 12-year-old fashion, she just said, well, it didn't help. And I'm not going to do it again. I just thought the third time would be the charm, that the third time of self-injury would magically work for her. Fortunately, that wasn't the case. So even if you're off and saying it seems like it's helpful, it's tentative language enough for them to disagree with you, like that 12-year-old I had disagreed with me, and she's not self-injured since. And then sensitively express concern about the behavior, kindly advise against it for health reasons, of course, explore with them alternative strategies, which we're going to get into in the next hour, and then offer to make a referral for therapy. So I'm going to stop here and use the next 5 minutes or so for some questions.
Yeah, thank you so much, Dr. Westers, and everyone, please feel free to continue chatting in your questions. So we have a couple already. So one question was, is the increase in people who engage in NSSI because there are more people admitting NSSI or including a greater age range? So I think that was referring to the statistics on one of the first few slides.
Yeah, that's a question we ask ourselves a lot. And I don't think we have a clear answer, because before it was people just did it and they didn't tell anyone unless they were so severe in the behavior that they were in treatment, like inpatient. And that's where I think a lot of people got the word self-mutilation from. So is it now just people telling, sharing more that they self-injure? I suspect that rates have increased. I think partly because of the behavior becoming more well-known. And so more people trying the behavior out to see if it works for themselves. And if it doesn't, then they just leave it. It's not a coping strategy for them that they'll use. And if it works for them, they might keep trying it. And that gets tricky because, even if the function is interpersonally at first, like if a kid tells another kid, oh, this works for me, and then they do it because they want to fit in, we know that even if the behavior starts in that form, just like a social function that just experiments, it can become it can serve an emotional function later and get them locked into using that as a coping strategy most commonly. But yeah, so the question is, it because the social media and it's in the media now? I think numbers have pretty much plateaued right around 1 in 5 adolescents, and I do think that there was an increase, and partly because of it becoming more well known, people were trying it out.
Gotcha. Yeah, that makes sense. On that note, someone did ask, are there clusters among social or peer groups in schools or other cutters reaching out to each other on social media?
There are. I mean, that's the thing with social media and the internet. It's like a double-edged sword, because some go on there for support, and they may test the waters, like disclosing to strangers about their self-injury in those kind of communities to see how they might respond before telling their parents, before telling you as their mental health provider or anyone else or friend. Just kind of test the waters to see what kind of response they get. And others go and they do get triggered. They get triggered by some of the graphic images. There are communities where they're uploaded and they're just not helpful. They're very triggering for individuals who have a history of self-injury. I don't think seeing those images necessarily will put the idea of self-injury in someone's mind had they not already thought about it for themselves necessarily. Some cases might be, but yeah, so it's a double-edged sword. And I think there are groups, historically it's been people that are emo or goths, but you don't even have to be in those subcultures any longer. And it's very common for your straight A student to struggle quietly, or athletes that cut or self-injure in other forms without telling anyone. So
right. When you were on the onset slide and we're talking a bit about isolation during COVID, someone said there was a word that you used for feeling like you don't connect. Can you just remind us what that word was?
Thwarted belongingness. It's a technical
Thwarted
term.
belongingness.
Yeah, thwarted belongingness, and the other was perceived burdensomeness.
Great, thank you. Yeah, those are great terms. Let's see, we have some other questions that are coming in right now. So we'll take maybe a couple more questions, but then I know we have to move on to the next portion, so we can save the other questions that have come through for the end. But someone said that they had a client who began cutting at the age of 72, and from their perspective or from their understanding, would that be uncommon? Would the treatment look different for someone of that age?
72?
Yeah.
Yeah, there's this self-injury in the elderly is very understudied. In fact, there's only a couple papers that have looked at self-injury in ages 40 plus. In fact, I'm going to release an episode and a podcast in the coming weeks on that. But it is uncommon uncommon meaning prevalence rates are lower, but people that are elderly do self-injure. I mean, we know that elderly individuals are also, particularly males and white males that are elderly, are at elevated risk for attempting suicide. So I think they're also at elevated risk for other health risk behaviors like non-suicidal self-injury. So it's not that common at all, but it does happen. And I think that's this myth that we have, like, not that myth, but a lot of people think it's just a white teenage girl problem. But going back to the prevalence rate questions, one possibility, the reason that rates have increased is because more males are self-injuring as well, and that might account for the increase where most research is mixed on how like females self-injure more often than males, but some research shows that they're pretty much equivalent, but they might self-injure for different functions. But I think the treatment approach with a 72-year-old is going to be very similar, that type of treatment that I would do with a 17-year-old. Yeah. That's a great.
So on that note, you mentioned some of the demographic information there. So someone asked, are there differences in frequency, et cetera, on different populations, for example, related to race and ethnicity?
Yeah, that's going to be in the next episode of the podcast too. Acculturation can be a protective factor, particularly for Mexican individuals. And then African American males tend to self-injure more often than, say, African American girls. And with other race ethnicities, we don't have a whole lot of data. Part of the problem is sampling, especially early on research. The predominant sample sizes are just white. And even with the treatment I'm going to talk about in a minute, one of the effective ones was developed for white adult women with borderline personality disorder. So the little bit of the small samples that we do have show some similar rates, but among different races and ethnicities. And then when they vary, they don't vary significantly. I think Asian individuals are less likely to self-injure. African American boys, teenage males are more likely to self-injure than African American females, but I still think less frequently than, say, their white counterparts. And let's see, indigenous populations, however, there are, similar to suicide attempts and deaths, there are higher rates among the very small samples that we see. The percentage, it's hard to compare because there's such small sample sizes compared to the larger, white populations that we draw from. But the prevalence rates are higher among indigenous populations throughout the world. Here in the U.S., Native American, New Zealand, the Maori people, and I would say even in Panama, where I travel to a lot, the Kuna Indians.
Gotcha. Yeah, sounds like maybe there's some more research needed on some of those questions.
Yeah.
Thank you everyone for all your questions. I see we still have a lot coming in. So I think we'll move on to the next portion now just for the sake of time, but we will have another section for Q&A at the end of that. So we'll keep track of all the questions that have been coming through. Thanks everyone.
Yeah, thank you. That was some great questions. I hope we'll get more of those. So here's some common treatment approaches for addressing non-suicidal self-injury. There's the motivational interviewing. So you could, like I had just mentioned with the stage of change, where they are, asking them, only after you validated for them, exploring with them what it's costing them, and just using general motivational interviewing strategies. DBT, a lot of you are already using that in your treatment, and that's very common, a very common treatment approach for self-harm. Again, the umbrella category under which is NSSI and suicide attempts. Mentalization-based treatment for adolescents, that's more common in the UK and Europe. But there was one study that showed that it helped reduce frequency of NSSI. But that study, I even tried to get the treatment manual. I couldn't get the treatment manual, even though the paper said you could. So I take it with a grain of salt. And then online daily diary and therapeutic evaluative conditioning, mobile app. There was some research there. I don't think this is openly available for people to use, but there's some evidence to show that some studies that have shown that has been helpful. Problem solving therapy. There's some useful utility there. The cutting down program is a very CBT-based program. It's short term, 6 to 8 sessions. I want to say I was going to talk about it in this presentation, but decided to spend our time with the next two. But that's based out of Germany, I believe, and it has some good evidence coming with a randomized controlled trial among adolescents in particular, with some good effects. But the treatment for self-injurious behavior, T-SIB, and then emotion regulation group therapy, ERGT, is what I want to talk about today. And the developer for the treatment for self-injurious behavior is Dr. Peggy Andover, who's actually at Fordham University in New York. So some of you might even know her. She developed this, and it was developed specifically for young adults. And I've adapted it in my work with adolescents. And then emotion regulation group therapy was actually developed for the most part for adult white women with borderline personality disorder. And now it's been expanding to other populations that are, some males, non-white individuals. And then there's some trials that are going on in Sweden and New Zealand, as well as here in the US, with emotion regulation individual therapy for adolescents. So that's an expansion of ERGT to adolescents in an individual therapy program with parent components. And there's actually an online version and an in-person version. But I want to just talk about the elements of T-SIB and ERGT, because I think most of you are probably going to be using the elements of these two specific treatments most often, because T-SIB is CBT-based with some DBT elements, and you'll see that in just a minute. And then ERGT is very DBT-based with acceptance and commitment therapy components. So treatment for self-injurious behavior, T-SIB. The first pilot trial was published in 2015, and then a randomized controlled trial in 2017. So T-SIB was developed as a 9-session CBT intervention to target NSSI among young adults with and without borderline personality disorder. And there's a heavy focus on functional assessment. So it's a very behaviorally oriented intervention. And in the pilot study that I just showed on the previous page, 12 young adults with a mean age of 22 who had engaged in self-injury in the past month or had the urge to do so in the past month, the majority of those actually who completed the program experienced a 50% reduction in both NSSI urges and behaviors at 3-month follow-up with medium to large effect sizes. So that was good news. And then in the only randomized controlled trial, which included 33 young adults, again with a mean age of 22, who endorsed NSSI urges and or behaviors in the past month, there was a significant decrease in NSSI at 3-month follow-up. But this was also evident in those who participated in both T-SIB and who were in the treatment as usual group. So at 3-month follow-up, they both benefited. But a closer look at the data showed that there was a significant difference between the two groups beginning at week 6, which when we go through this, it'll make sense because it's week 6, weeks 5 and 6, where there's a decrease in NSSI frequency, because that's when the participants are asked to start behavior change. So let's break it down into just an overview real quick of the 9 sessions. So the first session is psychoeducation about NSSI and conceptualizing it like I have as a coping strategy for emotions. And if they're ambivalent, they don't see it as a problem, you can use some motivational interviewing to help them hopefully move along in the stages of change. And then sessions 2 through 6, you hone in and do a lot of functional assessments using the ABC chart, the ABC model, antecedent behavior consequences, and then identifying alternative behaviors to self-injury, which goes back to my earlier comment in the first hour on exploring the reasons for self-injury. I use the word reasons, but really it's the functions of the behavior. Like I said, the greater number of functions, the greater likelihood of attempting suicide. But once we figure out what the function is, this is where T-SIB comes in, and we start to look for replacement strategies that serve the same function, albeit maybe not as quickly or as effectively, but we start practicing it. In other words, addition is better than subtraction, typically in this case. Adding healthier coping strategies is better than subtracting unhealthy ones. But in T-SIB, the focus is more on just like awareness and analyzing using functional assessment. And then sessions 7 through 8 really depends on the primary focus that comes out of those functional assessments. And there are 3 different modules depending, and you could use all 3, but when they do the actual research of the treatment, they stick to the 9 sessions and really just choose one of those 3 individualized modules based on what has come out of the functional assessment. So if the antecedents to the self-injury are because of interpersonal communication problems, so the social reasons for self-injuring, then you would hone in and focus on the next 2 sessions using the interpersonal communication module. However, if it's more of a lot of cognitive distortions contributing to the urges and behaviors of self-injury, then you would choose the cognitive distortions module to address the maladaptive thinking and start modifying those. And then distress tolerance would be the third. If it's more just needing to cope with emotions in general, then that might be the way to go. You'd use that. And each of those are 2 sessions. And then session 9 is just kind of like what we normally do in a final session with a client or patient, is reviewing the gains, consolidating treatment goals and gains, and then focusing on relapse prevention and termination. So let's walk through each of these. So the treatment for self-injurious behavior, T-SIB, session 1, the psychoeducation. Here are some sample questions you can ask your client about self-injury. And similar to what I talked about, like the functions, like what does self-injury mean to you? And this is very interesting. Has anyone ever misunderstood your self-injury as a suicide attempt? You'll be surprised what might come of that. And again, taking the role of like learning from an individual with lived experience of self-injury. If you want to start a little bit further, make it a little bit easier, you can start asking them about their friends. Any of your friends self-injure, what your friends think about self-injury, and then start exploring some of the consequences like of the self-injury. So in T-SIB, when we're asking about, again, like kind of using some motivational, interviewing here, asking about like what it does for them versus what it's costing them. In T-SIB, the focus is really on the nuance of language here. So when you're asked like, what does it do for you? And they like the positives, they might say, like, well, it helps me cope with my emotions, and then and then they suggest using a close-ended question. Is there anything else? Is there anything else? Is there anything else? Like yes or no. If there isn't, because we don't want to like give them too many reasons. Yeah, you should self-injure. These are all re-inquiry. So there's more of like close-ended, and then looking at the cons to the behavior, what it's costing them, instead of saying, is there anything else? Actually asking what else, because that's open-ended. And because we want to put on the balance more weight on the cons than on the pros. And then you can assess motivation for change. I actually don't do this as much. I'll usually ask for like urges, but as far as motivation, on a scale from 1 to 10, with 10 being the least motivated and 10 being the most motivated, how motivated would you say that you are to change your behavior? And then asking them why they're like a 3 instead of a 1. And then how certain are you that you'll be able to change your behavior? Kind of seeing where like hope for change, because a lot of people, not only they don't see a need for change, some just don't even know that change is possible. They feel like this is their lot in life, that this, for some, they call it an addiction for themselves. Like they feel it as an addiction. And so they don't realize, oh, actually, this is a behavior I can stop. So session 2 really starts introducing the functional assessment. So you use the ABC chart. A lot of you, you CBT folks are probably using already, behavioral therapy folks. And then identify alternative behaviors to self-injury. So the way that you might introduce when you teach the ABC model is like, this is going to be an objective observation of the events and emotions leading up to self-injury and the consequences. And then you're going to want to include at least one instance. I think I had some I'll have to edit that. Sorry about that. Include at least one instance of each method of self-injury, beginning with the most recent. So like if they self-injured this past weekend, let's focus on that. It's fresh in the memory as opposed to one a month ago. Even although you might choose to figure out to analyze the one that was the most severe episode if you want. But most recent is probably easier. And rather than starting in the A for the antecedent, just jump right into the behavior. The behavior was self-injury, and we'll talk about that in the next slide. And then from the B, move to column A. So kind of going backwards to the antecedents and ask about the triggers and rate their mood. Like, kind of get an idea of their level of distress on a scale of 1 to 10. I do this. I do the scaling of 1 to 10 here. And then go to the consequences, the C. So jump back to the end and identify the consequences. And then we want to emphasize any worsening of mood that happens after the self-injury when you're reviewing that episode, because you want to build that discrepancy and a reason for them to stop. And I'm going to give an example of a patient of mine in the next slide. So for homework, you'd give them, because it's very CBT based, at the beginning and every session forward, beginning and end, do a functional analysis for each self-injurious behavior and or urge. At this point, though, we're just doing a functional analysis. We're not telling them to do anything else. We're not telling them to stop self-injury. And we're going to start to explore alternative behaviors, but that doesn't come until later. So this is a document that I created that I use with the individuals that I see, that I treat who self-injure, and it's an example of the antecedent behavior consequence using the T-SIB module. So I start in the middle column. So I'm going to use an example of a 17-year-old female that I see who self-injures pretty often, and she actually self-injured on her legs during one episode and didn't tell anyone. And it was like, they were still bleeding days later. And she finally told her mom. They called the pediatrician. They said to go to the emergency room, and she required stitches, like I think 17 or 19 stitches, and topical antibiotic as well as oral antibiotic for treatment, and was admitted to an inpatient program. And understandably so in this case, because it was really severe. And that's why I want to ask like how they manage, like how they treat the behavior after. But one of her goals, and I asked her, it's like, if this is something she wanted to stop, and she said yes. So I'm like, I'm holding on to that and reminding her, yeah, I know, I remember one of your goals is to stop self-injuring. So there was a time where it was Halloween. Actually, it was, yeah, Halloween. She cut on Halloween this past year. And so the behavior, she used the razor from her shaver in the shower in her bedroom. And she had, I forget how many times it was and how long the episode lasted, but it was, maybe 10, 15 minutes on her legs, I believe, again, or maybe it was her arms. But asking the intensity, the urges, that's where I got the intensity is a little unclear. It's a little bit less helpful here, but we just really analyzed the behavior, what it was that she did. And she's like, I don't know why. Like, I just don't know why. I was just feeling sad or anxious or something. And so I was like, well, let's take a look. And so we then moved back to the antecedent, the first column, and looked at what was going on and where was she? She was alone in her bedroom in the bathroom. Emotionally, she was feeling anxious. What was she thinking about? Trick-or-treating. She was thinking about going out trick-or-treating with her family, her cousins, and dreading going up to the door and saying trick-or-treat in order to get candy. She was dreading so much, and she was so anxious. I forget what she rated her distress as. I think it was like a 7, 8, 9, or 10 that she cut. And then the consequence afterward was she felt good. I mean, that's not an emotion. She felt relieved and less anxious and less sad. But then when we started looking at the emotions and cognitions here, she was still alone in her bedroom. Emotionally, though, that relief lasted like 15 minutes, and then it turned to guilt. And so typically she's self-injured to relieve the emotion of sadness or anxiety, and in this case, anxiety, and it worked. But when I asked her, like, well, how long did you feel that way? And she's like 10, 15 minutes. And then how did you feel? Guilty for having done that. And also anxious because she was still going trick-or-treating. And she ended up trick-or-treating, but it wasn't as fun as she had hoped. And then another week she came, and she had cut very similar circumstances in the bathroom with the shaver or the razor, and went to the antecedents. She's like, I don't know what, like, just came out of the blue. I was just feeling anxious, sad. Then we looked at some of the cognitions and what was socially going on. What was she thinking about? What was she going to do? It was a Sunday. She was going to go with her family to the market with a lot of people there, and she has a history of trauma, and so she has the cognition that people are dangerous, and so she's out there like thinking that being out in the market, even though she'd be with her family, she's going to be exposed to different people that could be dangerous. And so really anxiety provoking for her. So she coped by cutting. And again, I asked, like, so did it help? Or how did it help? She's like, it helped. It's like, wait, for how long? Like 10, 15 minutes. Oh, and then what? Like, and I just felt guilty and anxious again. And so really we're starting to highlight, it's like, so it helps in the short term, but not so much in the long term. So that's kind of how, and even her mood and distress was down a little bit, but still it was pretty elevated. So with the cutting, we're able to point out, it's like, it's just not really working for you. It's not helping. And we did this for another incident. And I think it was because of sadness, feeling of sadness. And in the same thing, it just in that case, it didn't even help at all. And so I started to really build on that discrepancy. and she became more motivated to stop. But this is still getting ahead of ourselves, because right now we didn't even ask about stopping, but this is just kind of how I use that functional analysis. So session 3, you're going to conduct functional assessments of instances when they experience those antecedents, those triggers that often lead to self-injury, but when they did not self-injure. So in my patient's case, it might have been like a social situation that she felt the urge when she was at school to self-injure, but she went outside the class, sat down in the hallway and cried, but didn't cut, even though she wanted to. And so being able to use that and figure out like, what did she do that in that moment that was so helpful that kept her from self-injuring, and then start looking for these patterns of triggers. So for her, I could tell it's like anticipation of social situations was quite a trigger for her. And then in session 4, we're going to start identifying alternative behaviors and practices more specifically by creating a list of distress tolerance and replacement behaviors, again, with similar functions as the self-injury. And then the practices, the homework is to practice these behaviors in response to instances of minor stress. So in both sessions 3 and 4, the goal isn't to practice these alternative behaviors that serve the same or similar function as the self-injury when the urge to self-injure occurs, but not even apply it to that. Just apply it to minor moments of distress, such as maybe, I don't know, the dog got loose and she had to go, go get the dog. So that's pretty distressing. Or maybe she just learned that the owners, like the house that they're renting, is not going to let pets stay in, allow them to have pets, but they didn't give them a deadline. So it's still distressing, but not to the point that she wanted to self-injure. And so again, we're not asking to replace self-injury, and we're going to talk about the stepwise fashion in a moment. But this is from the SOARS article that I usually talk about in the first half of the presentation, but finding out the reason, the function of the behavior is really important, because I think we just sometimes pretend that doing something different that serves a similar function is really easy, but in reality, it takes a lot longer. For instance, if they self-injure to find relief from emotional tension, we might explore alternative strategies like talking to a friend or a parent, or journaling, drawing, exercising, using relaxation techniques. Well, let's use journaling as an example. I'm a huge fan of journaling, a huge proponent. A lot of you probably encourage your clients to journal in therapy, and I love it. But that takes time to articulate, formulate thoughts and feelings and put them on paper, that eventually will hopefully find relief as we kind of like make sense of our thoughts and feelings and put words to them on paper, versus cutting instantaneous relief for the most part, even if it's only 10-15 minutes, like in my case of the kid. So so exploring alternative strategies is going to be helpful, like that serves similar functions. And I think about like doing something to feel self-injuring, to feel something if they feel numb or empty. When I was in grad school, I worked with a 19-year-old girl who was self-injuring for multiple reasons, and one was to find relief from emotional tension, but also sometimes she didn't feel any emotion at all, wanted to feel something because she was feeling numb or empty. And so we talked about, the DBT strategy of ice diving, filling a bowl full of water with ice and kind of splashing herself and kind of jolt the senses to maybe tap into the emotional side of things, of those senses. And I encouraged her to get a hot pepper, buy a hot pepper at the grocery store, and she felt numb or empty and the urge to self-injure, to use that as a replacement strategy, to bite into the hot pepper to kind of jolt the senses. And then the next week in therapy, she came back and said, I did what you said with a hot pepper. I went out and bought one. And I was like, oh yeah, tell me about it. Did it help? Did it work? And she's like, yeah, I wanted to self-injure, but I took a bite in the hot pepper and it worked, but it was so hot, it was miserable. I never want to do it again. And so it worked in that case, and it served a similar function, but she didn't want to do it again. And then let's say someone self-injures to communicate with others. Remember, like to get attention or to activate the resources in the community to communicate with others. I worked with a 17-year-old who turned 8. I saw her from like 16 to 18, who self-injured for many reasons, oftentimes for emotional relief, but many times to get comfort and communicate with her mother. She would get into an argument with her mom, go to her room, cut, and then her mom would switch into caring mode at that point and start being like, baby, don't do that. Like, I'm here. Let me, talk to me. And so she and I talked about what she wanted to communicate to her mom, what she needed from her mom in that moment. And so we explored things like, maybe in that moment, when you're arguing with your mom, you just want her to sit in silence with you and be quiet, and not touch you. Or maybe you want her to sit in silence with you and be quiet while hugging you, and embracing you. Or maybe you just wanted her to give you advice or just to encourage you, but not touch you at all. Or maybe you just wanted 5 minutes alone and then her to come in, and it could change in any given moment. And again, this is one of those things that takes practice. My wife is great at telling me what she needs from me in a given moment, because it's hard for all of us to be able to say how we feel and what we need from our partner, significant other, or a parent, let alone having a young person or someone in emotional distress who self-injures, expect them to do that. But with practice, she was able to do that with her mom, and eventually she stopped self-injury. But she was also texting her friends at times and saying, hey, I'm thinking about cutting. And a friend gets a text like, what are you supposed to do with that? And so her friends were like, don't do it. And so she would do it anyway, and then text them back and say, too late, I already did. Or sometimes she would just take a picture of her wound and then text it to them. Now, that's just not fair. And I know Connor had mentioned earlier about resources that I'm going to share later. One is parents, how parents can talk to their teen about self-injury, but another is a resource document that I created with this girl in mind about helping a friend who self-injures. So we talked about what she was trying to communicate to her friends, what she needed from them. And she's like, I just want to know that they care about me. I was like, okay, so a friend might not know what to do when you cut, but what if, you were to express how you're feeling in that moment and say, hey, I'm having a bad day. I feel sad. I need some encouragement. A friend know exactly what to do there. So she started doing that, and her friends started texting her back. She wasn't even telling them she was thinking about cutting at that point. She was just saying she's having a bad day and needed some encouragement. And so they're saying like, oh, you're super smart. You're hilarious. You're the best on the basketball team. You're pretty. And then that was exactly what she needed. She stopped self-injuring altogether, but was triggered at one point months down the road, about 6 months later, when an underclassman on the same basketball team had learned about my patient's self-injury and started texting my patient saying, I'm thinking about cutting. And then she sometimes would send the image to my patient, and my patient was like, I don't want to be friends with this person. And I had good enough rapport with her at this time to say, like, so you kind of know how your friends felt in that moment. It was really hard. It's just not that fair to be put in that position. And so that's when we put together that resource I need to update it, but helping a friend who self-injures, but finding what the function serves. And this is a document that you can find through the Teen Steady workbook for depression. And it's a bunch of activities, like it's front and back. There's like 200 some activities that you can do. And this might be something I would supplement and just give my client, my patient, talking about when you're feeling emotionally overwhelmed. Take a look at this list. Maybe some of these will serve similar functions to your self-injury. Or we're not at that point in T-SIB yet. We're not going to necessarily need to replace the behavior, but any types of emotional distress. Maybe you want to, let's see, what's something on here. Give a gift to someone, or go for a drive for, as long as you're not super angry, and making sure you're thinking straight to drive safely. You could, get a job, go to work. Let's see what else is on here. Have a good laugh, watch a funny movie, and talk to a friend. So this is a list that I'll give. Some of the things are out of their control, like meeting a celebrity, unless someone's in town already, but you can't necessarily control that. And there's some other ones on there that probably are not necessarily the most appropriate. But that's sessions 3 and 4. And then in session 5, we're revising sessions 5 and 6, revising this list of alternative behaviors. And it's now at this time as like figuring out what works or what doesn't work. Some things that might work that we didn't think would work, but the things that we thought would work weren't really as helpful. So refining this list, discussing the successful and unsuccessful consequences of some of these behaviors. And now is when we ask them to start replacing using these replacement behaviors and testing them out in response to self-injury urges and behaviors. So you can ask them, like, do you think you're ready to apply this to self-injury or to cutting or burning, whatever it is that you do? So this is, again, if you think about the randomized control trial, it was after session 5 when we first start asking them to apply this to self-injury, that there was a difference between the T-SIB group and the treatment as usual group. And we also want to be honest, like I said before, like it takes practice, a lot of these. And if we're rating their distress on a scale of 1 to 10 or 0 to 10, and 10 being most distressing, with thoughts and urges to self-injure, maybe talking to a friend doesn't get them down to a 0 or a 1 or even a 2, but it gets them down to like a 7. Well, we want to take a stepwise approach. So you use that. And then what is something else from that list that you can use as an alternative? Okay, watch a funny movie. That's like what, an hour and a half, 2 hours, and then document your mood after that. And then we find that it's down to a 5 or a 4. Okay, what else might be helpful? Maybe go for a walk, and that brings them down to a 3 or a 2. And at some point, maybe it's just okay to learn to sit with a 2, 3, 4 level of distress and be okay with that. So after you've done all these functional assessments and you find out like what are the most common reasons, the common antecedents, then you can choose your select individualized module. And the first one is interpersonal communication. And this is very DBT. It's basically, I think interpersonal effectiveness from DBT. So it's in session 7, talking about balancing respecting the rights of self and others. So becoming assertive. I was just having a conversation with a patient of mine yesterday who no longer self-injures, but has a history of self-injury and suicide attempts, but has this very strong desire to maintain friendships and be very, very passive and is a doormat, basically just do whatever other people do, even though he doesn't want to. So we talk about being assertive doesn't mean you're going to get your way, but it means that you're respecting yourself by telling people what you need and want in a way that also respects the other person. So that it's this balance of being assertive, as you know, is a balance of respecting the rights of someone else as well as our own rights. Being passive is respecting the rights of other people at the expense of our own rights. Being aggressive is respecting our own rights at the expense of other people's rights. So finding that balance is that assertiveness. And then then you can use the DEAR MAN acronym. So in session 7, you'll focus on the DEAR parts, the what to say, and then come up with a script together as homework, but not expect them to attempt it. And then session 8, you'll again use that functional analysis using the script homework as the behavior in the analysis. So if you use the script and how to say it using DEAR MAN is the behavior category and whatever the antecedent was, but the consequence, we can't necessarily control what the consequence is in this case in the functional assessment because it involves someone else. So even though it wasn't assigned, the client may have used interpersonal communication skills anyway. So we'll perform a functional analysis using the performance of using the script as the behavior. And if the actual consequence was not the desired consequence and they're making, asserting themselves and making the request, then we want to emphasize that successfully using interpersonal communication strategies is not contingent on the result, because the result involves another person whose actions can't be controlled. All the client can control are their own actions. And by communicating effectively, the client handled the situation successfully, regardless of what the desired outcome occurred. I think, and then you can use role play here with them. And I like to use an example when I work with teenagers of asking someone out. A lot of teenagers are so scared, and adults don't want to ask someone out because they're afraid of rejection. Well, that's because the consequence, the expectancy is a yes. But if the focus is more the communication strategy as a personal growth, we're not necessarily, it may be great if they say yes, but the goal isn't for them to say yes. The goal is simply for you to ask them out. If they say no, well, you've already accomplished your goal, which is great. I mean, it might be disappointing appropriately so that they said no, but no harm, no foul. Like you don't need to necessarily self-injure as a result because you accomplished your goal of asking them out. If they say yes, that's just icing on the cake. That's just the cherry on top. That's great. And then the other module is cognitive distortions for you CBT folk. So we went from DBT, now CBT, looking at using the thoughts, feelings, behavior cycle. identifying cognitive distortions. When you use your distraction techniques and you don't self-injure, how do you feel? What do you think? How is that different from when you do self-injure? And then identifying and evaluating the thoughts. And then the homework would be to identify the automatic thoughts so they're not so automatic, that are related to self-injury, and some that are just not related to self-injury. And then the next session, you continue with automatic thought records. And so here's your CBT cycle: thoughts, feelings, behaviors, and how they influence each other. And here's an example of risky automatic thoughts that we use in one of our programs here, our suicide prevention program, just to kind of help like teenagers maybe check off some common cognitive distortions by calling them risky automatic thoughts. But I usually will use a thought record. I created more of a 4-column technique. I know Mind Over Mood has, was it in 7-8 column technique, but just a little bit overwhelming for most of the people that I've worked with, both young people and adults. But yeah, we're gonna explore the evidence for and against, like especially if it's cognitive distortion that leads one to self-injure. This could be the interpersonal effectiveness as well. Like, no one likes me, like, and so I deserve to be cut. I deserve to hurt myself. I was like, well, evidence for? Has anyone ever told you they don't like you? And that would be evidence for that thought. But what about evidence against? How many, like, you just named all your different friends. I don't really call people my friends if I don't like them. I don't spend time with them if I don't like them. And then coming up with a balanced alternative thought. And then lastly, and then we'll move on to the next one, is the distress tolerance. Again, building from DBT, CBT, and a little bit of acceptance and commitment therapy here. So continuing practicing those replacement skills based on the functional assessment, functional analysis for self-injury, and learning to accept distressing situations and feelings. So you're going to discuss the concept of acceptance and distress tolerance regarding situations and feelings. So there's a difference between pain and suffering. We suffer when we don't accept that an event has occurred. When we accept that there is distress, really, in life, we feel pain, but we don't necessarily suffer. Suffer occurs when we deny a situation or we deny our feelings in those moments. Rather than automatically avoid or remove the distress, we need to learn to tolerate it so that we can deal with it appropriately. So the first step here to tolerating a situation is accepting yourself in the situation. When we say, but then in T-SIB, when we say accept, we don't mean that we like it or that it's okay, of course. All we mean is that we perceive our situation, our thoughts, our feelings, and behaviors, and we recognize them without attempting to judge them or requiring them to change. We're accepting without judging, but this doesn't mean that we approve of the situation. So I think it's always important to clarify that. So dealing with distress versus tolerating distress. And then lastly, the last session is going to review like your treatment goal and the gains that you've made. And then you can also review if you've been assessing motivation for change on every session. You can show them how much they've changed and the motivation and how much hope they have. You can use a graph or a diagram. I've not done that. I don't usually do that, but and then you can ask them, of course, what's been most helpful. So I want to spend most of this time talking about T-SIB because I think we have a lot of DBT folk here, and you can actually reach out to Dr. Andover in order to get the actual manual to help you walk through some of this stuff and get a better understanding. And again, it's in episode 10 of the podcast. I think in the episode notes, I actually include a link or her email, so you can email her. That's how you can get the treatment manual. Next is I really like, I don't do this as clearly as I do T-SIB, but I use elements of emotional regulation, group therapy, emotional regulation, individual therapy for adolescents. I use elements along with T-SIB and integrate them in addressing my patients' needs. But yeah, this was initially developed for, like I had mentioned, adult white women with borderline personality disorder, but it's now been expanded to others. So with 2 randomized controlled trials evaluating the effectiveness of ERGT with adults, they found significant reductions in self-injury frequency and severity among participants in the 14-week intervention group when compared to treatment as usual. Let's see, here we go, okay. And then uncontrolled trials of ERGT have actually shown similar results in both the US and Sweden. I mentioned Sweden before, and New Zealand. ERGT, is, I had mentioned, has been adapted for adolescents in the form of a 12-week individual therapy versus a 14-week for the adult version, and with an online parenting program for the adolescent version. And so 2 uncontrolled trials of the emotion regulation individual therapy for adolescents have been carried out in Sweden among adolescents who meet DSM-5 proposed criteria for NSSI disorder that we talked about in the first, so you know exactly the group that they were looking at. And the first study found significant improvements in self-injury among 17 adolescent females, again, just only girls though, showing significantly lower frequency, but with a large effect size and fewer number of self-injury methods with medium effect size of past month self-injury at post-treatment and 6-month follow-up. So the second study, which was the online version of ERITA, or ERITA, I forget how they pronounce it, showed similar results among 25 adolescents meeting criteria for NSSI disorder. So there's some good promising results here. True to form with acceptance and commitment therapy, the focus isn't so much on controlling emotions and getting rid of uncomfortable feelings, but more on increasing emotional awareness and clarity. So it's a lot of psychoeducation, and then altering our relationship with emotions, and very relevant for individuals who self-injure because of emotional tension and distress, helping them become willing to experience some of the distress and sit with it rather than immediately go to self-injury. And I think is really, but not expecting them to always do that. And I think there's room for, for growth or for flexibility, I should say. And then loosening that relationship between emotions and behavior. So this willingness to experience uncomfortable emotions, unpleasant emotions, as a part of pursuing meaningful activities in life. So you can see kind of the content weeks 1 through 14, where it's of like function of self-injury, function of emotions, emotional awareness, so a lot of psychoeducation, and then differentiating between primary and secondary emotions. But if we, let's see, looking at time, yeah, let's run through a few of these weeks and then take some time for discussion. So look at the function of the behavior, and we want to target the shame that's often associated with self-injury. So if you were to use this, and I use this sometimes just in my regular practice, you can draw it on a marker board or a piece of paper. Again, list like the positive and negative short-term consequences using that functional analysis of the self-injury, as well as the positive and negative long-term consequences. So you probably want to start in the top left quadrant, because it's probably easy for them to identify the positive short-term consequences. I mean, most often it's probably going to be emotional relief, like immediate relief. And then some negative short-term consequences might be, I don't know, having to clean up, and then a negative, and then continue in the negative role. And we really want to highlight the negative long-term consequences here. And that's going to be inability to deal effectively with their emotions in a healthy way. Another negative long-term consequence might be, loss of friendships and relationships or conflicts because of that, and really bolster that. Again, that's building motivation for change. And a positive long-term consequence would be the last thing you touch on. And there's not really much. Let's say that they self-injure to avoid suicide. Maybe that would be the positive long-term consequence. I'm alive. So that might be the one positive long-term consequence. Weeks 2 through 5 talk about the functions of emotions in order to increase emotional acceptance, and then becoming more aware of our emotions. I know we talk a lot about mental health nowadays in the media and social media, but I don't know how helpful necessarily that has become if we don't talk about it correctly and helpfully. So making sure people can identify how they feel and recognize that you might have multiple feelings at the same time. And again, right now, this is just focused, not even talking about self-injury. This is just learning about emotions. And then primary versus secondary emotions, very DBT-based. So I think about primary emotions being the naturally elicited emotions that a circumstance or situation elicits. And then the secondary emotions result from our judgments about our primary emotions. So sadness, I shouldn't feel sad. Like other people have it worse than me, so now I feel guilty. Well, the sadness might serve a function, but the guilt doesn't serve any function other than to make me feel miserable. So helping them differentiate primary and secondary emotions there. As well as clear versus cloudy emotions. That's a little bit more difficult and complicated. It's probably the aspect of the intervention that I'm least comfortable with. And then weeks 7 through 8 is emotional avoidance and unwillingness versus acceptance and willingness. And I really like this part because it talks about the paradoxical effect of emotional avoidance, in that the more we avoid our emotions, the more we experience them intensely, more intensely than we normally would have we just allowed ourselves to sit with that emotion and let it metabolize or pass. So yeah, I know a lot of us spend much of our lives running away from our emotions rather than just sit and experience them. But the part of it isn't necessarily always being willing to experience every emotion at every given moment. That might not be realistic. For instance, if in a job interview, someone that might be really overwhelmed because they lost a loved one the other day, well, they're probably not going to bring that and just like cry, weep openly necessarily in that job interview, because that might not be, appropriate at that moment. So sometimes we want to be able to be, but willing to experience that emotion when we're on our own or with friends, talking and reminiscing about that person that we lost. And we talked about pain versus suffering in T-SIB, where pain is a part of life. Suffering doesn't necessarily have to be, especially if we can just, sometimes we have to accept things as they are to decrease the suffering, because avoiding our emotions tends to persist and keep our suffering going. And then we have non-avoidant emotion regulation strategies. So this is the first week to emphasize behavior change, kind of like T-SIB. The first session was session 5. We wanted to start replacing self-injury urges and behaviors with the alternative behaviors that we talked about. Same thing here. We want to do that in week 9 and redirect attention towards something else for a while, and then come back to it, back to the emotion. Sometimes that's helpful rather than just avoiding all the time. Weeks 10 through 14 is very much acceptance and commitment therapy focus act. So, well, impulse control, maybe not so much, but weeks 11 through 14. So week 10, you're going to do a chain analysis or a functional analysis of the behavior to see what the consequence was, and in order to highlight the importance of controlling our impulses and use some behavioral substitution, kind of like that long list of things that we hit, a long list of activities that I shared with you earlier that I might incorporate here at this point. But I know one of the favorite parts among those who've done this intervention is weeks 11 through 14, because it talks about values and living according to their values and identifying and clarifying those values, the things in life that matter or are meaningful, and how sometimes we have to do uncomfortable things to live according to our values or get to where we want to be. And so we commit to that. So it necessitates weeks 13 to 14, necessitates willingness to experience difficult emotions as part of pursuing meaningful activities in life. And that might be with school, for someone that's in school, being able to I think all of us were willing to experience the distress of exams in order to get to our ultimate goal of becoming a clinical therapist, psychologist, or social workers, or whatever role you might have. But at the same time, that's not necessarily a value. Like a value could be just learning and like studying. I think here the difference between goals and values are goals are future oriented. Values are things we can do right now. We don't have to wait to graduate, but we can learn. We can be nice. We can care about others, or we can work hard. We can do that now, but we might not be able to get straight A's until later. So in the SOARS article, to come to a close, these are just, again, some common approaches and how they might show up in a brief intervention. If you were to do a brief intervention, obviously the T-SIB was 9 sessions, emotion regulation group therapies, 14 sessions, emotion regulation individual therapy for adolescents is 12 sessions. It's a little bit shorter. So there are different interventions, very few that are really designed specifically for adolescents that are evidence-based. But I incorporate a lot of these evidence-based treatments for adults that I might use in my work with adolescents, as well, like DBT as well. Some of my favorite resources I have listed here, some books, and I'll send a list of resources as well as part of one of the handouts. One one of my favorite books as a clinician is the Barry Walsh, Treating Self-Injury, there in the middle. And then Healing Self-Injury is a book for parents you might recommend for parents. It's a little bit long, it's a little bit thick, but it's probably the best book for parents that's out there right now. There's not really much, there aren't very many good books to recommend to parents about how they can help their child who self-injures. And then a book by Bo Mole, Assessment and Treatment of Non-Suicidal Self-Injury. I think as a clinician, I really like that book too. And when the Handbook of Non-Suicidal Self-Injury comes out later this year, that'll be a book. I've contributed a couple chapters to it, but there are a lot of chapters in there that I'm really excited to read about that I think will be a huge resource and for people. Websites, I listed the top 5 websites on self-injury here as resources. There's a lot of websites. In a 2015 study or 2014 study on Google, if you do a Google search, they looked at all the websites that are through Google and found that almost every website perpetuated at least one myth of self-injury. And so these websites here don't do that. These are the most reputable. ISSS, the International Society for the Study of Self-Injury, of which I'm a member, and I chair the media communications committee for that organization. SIOutreach.org, selfinjury.com, selfinjury.bctr.cornell. Dr. Janice Whitlock, who's there in Ithaca at Cornell, she has helped develop this website, which is one of the best. The SIOutreach.org and the Cornell page are some of my favorites for sure. They have a lot of resources. Some of you have probably already have used them. And then for the people in Australia, and you can also access it here, selfinjury.org.au for an Australian-based website. So to summarize, about 1 in 5 adolescents are self-injured, mainly to engage, to regulate or cope with their emotions. And we want to differentiate it from suicide, use a low-key, dispassionate demeanor, respectful curiosity, assess factors that may increase risk for a suicide attempt. And even though there are no evidence-based treatments specifically for adolescent self-injury, there are some promising ones for adults and young adults. Some resources. And yeah, and you can follow ISSS, or you can email me at nicholas.westers@childrens.com if you have any questions. And then we have ISSS Twitter and Facebook pages. I'm on Instagram and Twitter as well, as under the handle @DocWesters. So I think we have some time for Q&A.
Thank you so much, Dr. Westers. That was amazing. We have received quite a few questions, so we'll try to get to as many as we can in the last few minutes. So one question was, how do you navigate the sessions that may be with an individual who isn't following along with the homework or anticipated path for the session, someone who is having difficulties in committing to the treatment plan despite the desire to stop self-injuring?
Yeah, that's tough. I mean, I see that a lot, and I think I'll revisit the goals, because I think I think change can bring ambivalence for some people. They want to change, and sometimes they don't. Like the girl with the tattoos with the sleeves. When it wasn't as easy as me just saying, yeah, her little sister came up to her, and then that's when she stopped self-injuring. It took a long time. There are times where she's like, yeah, I want to stop, and the next week I don't, and then I do, and then I don't. And I think I just kind of rolled with it, kind of like motivational interviewing, and reminded her of her goals. I always like to remind people of their goals, to like, well, I remember you did and wanted to stop self-injuring. I'm not sure if that's still something you want to do, or because I know it's hard. It's been your go-to for a while. I think being respectful of that, and yeah, I can't remember the rest of the question there.
Yeah, that makes sense. No, I think that really addressed it, just like the idea that someone wants to stop, but maybe they're struggling, completing the homework or moving at the pace that was outlined.
And I might highlight to them, because I think it's a lot of people think cessation of self-injury is the ultimate goal. And for some people it is, but for some people, maybe they're just almost like when we talk about substance use, maybe their goal isn't to necessarily stop self-injuring altogether, but maybe less frequently, like once a month or once, so it's not their go-to coping strategy, but just part of their coping strategy. Even though, of course, we're going to advise that they not, but if that's their decision, we also need to keep in mind, we don't see how successful every time that they've resisted an urge. We only see the physical evidence of their failures. There's a lot of successes, and I think that I think people with lived experience of self-injury sometimes feel like people don't see that, like those struggles that they've overcome time and again. They only see the times in which they gave into the self-injury.
Yeah, that's a great point. Someone also asked that it sounds like from this presentation that the goal is to move away from the NSSI behaviors to behaviors that do not cause injury. But in the past, they've heard that the behavior replacement should be focused on the reduction of lethalness. So for example, like using a rubber band on the wrist or something like that. So they were asking, should we move away from that sort of framework?
I knew this question was going to come up. I love it. So it really depends on your outlook. I think that's the harm reduction model would be to say, a rubber band snapping is safer than cutting, which is true, but it doesn't really address the underlying issue. It's just another form of non-suicidal self-injury. It causes tissue damage, albeit maybe not as much scarring. So T-SIB argues that the rubber band snapping is not consistent with the goal of NSSI cessation, because there's the functional analysis needs to focus more on the antecedents and what leads to the actual snapping of the rubber band, as opposed to an alternative coping strategy. So I think you're going to see some different schools of thought on that. If it's severe self-injury, I think rubber band snapping or other, minor, less significant forms of NSSI are more acceptable for lower lethality and concern. But ultimately, I don't think that we should stop there, because that's, again, condoning the self-injury in a way. We just want to harm reduction that might work, but on the way to the patient or client's goals.
That makes sense. So someone asked, how do you approach NSSI that is a coping mechanism for PTSD? In other words, if the stage of change is pre-contemplation in terms of stopping cutting and the underlying condition, for example, PTSD symptoms itself takes time to treat, how do you handle it?
That's tricky, because I imagine if we address the PTSD, then the use and need for NSSI goes away. And so I think the underlying goal, if we do a functional analysis and is self-injured to cope with a flashback, maybe the cognitive processing therapy or CBT or EMDR might be, more helpful. I think about research looking at nightmares for PTSD, and how even doing imagery rehearsal therapy or ERGT, which is what exposure reimagining rehearsal therapy, I think for nightmares, I think I got that maybe one of those R's wrong, but showing that being able to help people with PTSD sleep through the night by addressing their nightmares first actually is much easier later to address the PTSD itself while they're awake. It's a lot easier to address PTSD when we're better rested than when we're sleep deprived. So I think the same could be said, for self-injury, maybe, but in the other way around, maybe where it's addressing the PTSD addresses the need for the self-injury. But I think it's a very similar, using a functional assessment and not in people that want to stop self-injury. I think it's fair to expect relapses to occur often. Complete cessation is not realistic. And working with parents, they might want their teenager or child to stop self-injuring and view, like, if they self-injure later, that it's a complete failure. They've not made any progress. They need to monitor them. And that's not fair. Again, we see the failures, but we don't see the successes all the time. And so, I think accepting that.
Right. So it looks like we're just about at time, so we do need to close out, but Dr. Westers will be presenting another webinar with us on suicide risk assessment next month. So stay tuned for that announcement, because that we're really excited to be doing that as well. And we also have some other upcoming events listed here. So we have a 2-hour presentation of Jan Winhall tomorrow on trauma and addiction. We have a conversations with Dr. Tony on April 27th with Cindy Stanford. She's the founder of the ACEs Matter organization. So she'll be talking about her work around childhood trauma. And then we have another conversations with Dr. Tony on May 11th with Michelle Munson, who will be talking about engaging transition age youth in care. And then Dr. Westers, if you can just move to the next slide really quickly. So again, the recording of today's webinar and the slides and a lot of the resources that Dr. Westers was discussing earlier will be posted on our website, ctacny.org, in the next few days. So you can go check out those resources there. Once they're posted, you can also sign up for all of those upcoming events and see other resources and past trainings on the website as well. And we would really appreciate if you could take a moment to complete the brief feedback survey that will pop up in your browser once the webinar closes out. I think Kira also put that link in the chat box, so we'd love to hear what other topics you're interested in seeing us cover in the future. And you can always contact us via email at ctac.info@nyu.edu. So thank you so much, Dr. Westers. This was an amazing presentation, and you really went over a lot of really helpful info. So we're very excited to see you again in May. And thank you everyone for tuning in today, and have a great rest of your day.
Thank you.